Hi, my name is Chris. I'm from Hickory, North Carolina, and I work for. They are. So is Alpha in the farm. So we are an ASO. Alpha is an ASO that has been around for more than 30 years. We opened a syringe exchange in 2018, and we've also expanded to provide PrEP services, Hep C testing, and link to treatment. We have a mobile unit. We have several offices now. We've seen a lot of growth. So just some things that came up for me just listening this afternoon, which was wonderful. Thank you. First off, somebody did mention the funding for syringes, and I just really wanted to emphasize that is a huge challenge for us to raise the money. We're giving out 500,000 syringes a year. And I was telling a colleague over here, we get direct funding of $7,500 for that every year from a private grant. And so we have to scramble to make that. We don't want to reduce services, but it's just kind of ridiculous. We got a grant from the state that we can spend on anything we want to run a syringe exchange program. We can pay for staff, cell phones, rent, granola bars, tampons, but we cannot spend it on syringes, cookers, naloxone, and up until recently, fentanyl test strips. So that is ridiculous. Secondly, also related to that is I didn't hear anyone talking about safe smoking supplies. And that is smoking is a harm reduction tactic all on its own, reduces HIV and Hep C transmission, as well as, soft tissue damage, endocarditis, all those things. So those are things that really need to be elevated and advocated for. So my second thing on my list is housing. We operate a HAPA housing program, which is fantastic, but there's no housing. And the housing that is there is too expensive. We just got an increase of our fair market value, but it's still not enough. So we are having to put people in kind of, I won't say substandard because they obviously have to pass inspections, but not the most ideal situations for folks, maybe even moving them more rural than they want to be, which cuts them off from transportation and other access to services. So that is like a really big problem, as we know, housing first, but we've got people living with HIV, living under bridges. That's should not happen. And it's not because we don't have the money, it's because we don't have the house. Okay. And then the last thing I really wanted to touch on was the 340B safety net pharmacy program, which is a huge source of income for my organization. We started that program in 2018 also. And if the audience isn't familiar with that, safety net pharmacy program, and what we've been able to do with the funding from that, which is under attack by pharmaceutical companies. I'll just stop there. Anyway, it's under attack. We've been able to expand our agency from 8 employees to 18, open up another office, purchase a mobile testing unit, have another satellite office. We're providing services to 3 times as many people as we were in 2016. And we've got hundreds of individuals on PrEP in an area where PrEP is not easy to get. So, and another thing we've been able to do with that money is support low barrier Hep C treatment to people that are actively using drugs. So we do this in partnership with an FQHC that is the doctor's an advocate of drug user health. So this is very low barrier. People can come to our office. We can do all of their labs. They do a televisit with the doctor. We help them get their medication. We check in with them, do case management. And we're seeing a lot of traction with it. We've tried many models, and this is the one that's sticking, and that's supported by the 340B funding also. And also, having funding like that allows us to pivot. With COVID, we were able to provide services and be a testing center for our community when the hospitals and private practices were overrun. The hospital called us and said, please, will you set up your van outside of the hospital? Too many people are coming into the emergency department for COVID testing. So 2020, I think we provided 400 COVID tests, either through our mobile van or on site. And we still have COVID services. We were able to get a rapid molecular testing machine. We're just, so anyway, summing that up, that 340B money is so important to our agency. You know, it's supposed to stretch scarce federal funding. My agency gets $120,000 a year for HIV prevention for 9 counties. There's not much you can do with that. It does not support what we need. So that's all I have. Thank you.
Thank you for that.
Thank you.
If you're in the audience and you have a question, please raise your hand, or a thought, a comment. I would also encourage, this is an open conversation. So if anybody on PACHA has a question that they would like to ask the audience for, please feel free to do so as well.
I'm sorry, what was your name? Chris. I would like to ask a clarifying question. When you say safe smoking, are we talking about tobacco, cannabis, TINA? Heroin. Okay. Thank you so much.
Hold on just a moment. If you wouldn't mind waiting for the microphone, just so.
We have a live stream, so we want to make sure everyone online can hear as well.
So providing safe smoking supplies, glass pipes, etc., that is a racial equity issue as well. Don't get me started.
All right, I have a question here.
Actually, my comment is probably twofold. One is that I just want to really be on the record about figuring out a strategy for us to engage medically assisted treatment providers in this country, particularly in rural communities, because of the role that they play in the lives of people with lived substance use disorder experience. And what I think that we have to do is figure out how we're going to educate and train them to their role in our continuum of care for HIV viral hepatitis, particularly training them that linkages to care for HIV, testing for HIV care, testing for Hep C, and actually cure and PrEP. There are unique opportunities there that I would really like for us to figure out how we do it. And I think one of the first steps is making sure that they have the ability to actually screen for it, that it is a universal screen, that it's not an opt-out screen. That's certainly thing one. But I also really want to be on the record about the increased need for us to figure out a strategy for community-based organizations to move money across state lines. It should be in every federal notice of funding opportunity and application. And we have to figure out how we're going to allow these organizations, particularly rural ones, to actually address the needs of their communities and not in models that worked 20 years ago or 30 years ago and that are very urban driven. And that's my nickel's worth.
Thank you very much. Audience, PACHA. Jesse?
Thank you so much. I'm Jesse Milan. I'm the president and CEO at AIDS United. And as I mentioned earlier, I don't know if you heard, AIDS United has for 20 years managed the Syringe Access Fund, which is now the Harm Reduction Futures Fund, which has provided private sector funding for syringes across the United States, including funding about 1/3 of all the syringes exchanged. I think I'd like to know from you, what is the public-private partnership for supporting the harm reduction community in this area? We've heard that City Council rejected adding a new SSP in Charleston, but I don't think we have a full broad sense as to really how is the state government and the local governments here supporting the harm reduction community, and what is the private sector support for the harm reduction community, and what would you like us to do to help advance ending this federal ban on the use of federal funds to buy syringes? Are we doing enough, or should more be done? And if so, what would it be?
I can't speak to West Virginia because I'm in North Carolina. That really varies by county, how our services are received. We try to stay a little bit undercover. We don't advertise it on billboards. Generally, the community support is there, but we just don't want to ruffle any feathers. So we just keep it kind of quiet. We do get a lot of support. I won't say a lot, some support from congregations and private individuals and like-minded donors. And I know about your funds, but we do not qualify for those, unfortunately. So it's either, I find, correct, there's some, the qualifications include percentage of BIPOC as leadership. I'm the leader. So the rest of my staff is very diverse, but I'm not. So, and then also there's sometimes like funding because our agency does so many things. Sometimes our budget is higher than what qualifies, but we can't spend that money on what we need to spend it on. So that's a little frustrating. So, I mean, a personal ask would be to reconsider your considerations. And you asked also, what can you do? I don't know. I'm not a lobbyist. That's my next career choice.
Just a little refresher on the history of this. My name is Carol Treston. Oops, I'm a loudmouth. No. Years ago, when we were involved in the advocacy on the Hill around federal dollars through the CDC for syringe exchange, that was the compromise position, that in order to get it through, to have funding allowable at all, the compromise was that the funding couldn't be used for purchase of syringe. So that was the compromise to get the rest of the money for staffing and tampons and all the other things that you said allowable. You know, we're in a very precarious place politically. And so what I think one of the things that, you know, we have to think about sometimes is if we move in advocacy, and I'm not saying that we shouldn't, but it's always a consideration. Could sometimes some of these things backfire, and what you already have, you actually lose in the climate that we have. I don't know that for, you know, I haven't even thought about that with syringe exchange and funding, but we think about that with Ryan White reauthorization, for example, that, you know, maybe it's okay to just let it be, because if we opened it up to debate in this current political climate, maybe we would actually lose some. So I just wanted to point that out there, that I'm not saying we shouldn't advocate for loosening up the funding to allow for syringe purchase, but there's also that balance, right?
Are you taking comment virtually?
Yeah, I was going to check anything virtual.
Yeah, so the last question I asked about how syringe service programs are illegal in Alabama, what kind of federal incentives could be given to states that don't have this implemented to actually implement them on a state and local level? Because we need them, but we can't do anything.
So I'm just going to say a few things. The syringe service program issue it's been a toxic issue for West Virginia for the last 5 years. And it really varies from location to location, what this community's support is for it, which is unfortunate. And it does seem to me that the more push there is for them, the harder it becomes to do them. And what you said about knowing where to stop in terms of, you know, should we just maintain? And because if we bring up more discussion, then potential could lose more. So that's, I think, the current battle that we all continue to face is how much should we push with this? And we thought, once the problems reared their head and we did have a problem with relation to infectious diseases, that, well, sure, that legislators would come around and support evidence-based medicine, but it didn't happen. So, and the other problem for us has been that a lot of these issues, obviously they stem from 20 years ago, from when pain pills became an issue. But for Charleston, at least, HIV became a really big issue, or when we noticed a huge issue was during COVID. And so that really made it very difficult for us to continue to do any kind of implementation regarding syringe services, because every other service was being diverted to that. And because it happened during COVID, everyone was focused on COVID, and people were accustomed to hearing 1,000 new cases per day of COVID. And we were saying, hey, there's 10 new cases of HIV in Kanawha County, and that's so what? So just convincing people that that was an issue, getting them accustomed to numbers, has been a real challenge. And then just the fact of it's the population that is succumbing, to these things. There are people who are affected with substance use disorder. And there's the mindset that we can't really help the people until they get into recovery. And they're just going to, what's going to happen is going to happen. So there was that too. But it's been a real challenge, a real struggle, especially for us on the front lines that are dealing with the issues and have to also balance the fine line between knowing what the political climate is or isn't in some places. So what you all can do, I don't know. Just continuing to advocate for, best practice, what works, and to communicate with federal officials to really continue to bring attention to the problems that we face.
Thank you. I'd like to go back to the gentleman who's online. And maybe if you could take just a few minutes and share with us what you think needs to be done. Like, what is your ideal for that incentive program, or what you would like to see?
Well, currently, as it stands, with the legalization, or should I say the over-the-counter Narcan, I've spoken with the health departments and the DA's office, and they've all said peer-to-peer distribution of Narcan, such as if I were to get a large amount, go out to the unhoused community, hand it out as I see fit, there's no problem. However, intramuscular naloxone, which is the same medication, just a different administrative route, is illegal for peer-to-peer distribution. Because when you make a kit, you have to have a syringe in there. It's like an EpiPen. So my incentive program, offer more funding for the Alabama Department of Mental Health to implement a pilot program, like a limited pilot program, such over a certain amount of time. I heard one state or one city up in the Midwest did one for 30 days as a pilot program. Implement that, collect data, and then bring it to the governor of Alabama, bring it to the Alabama Department of Health and Human Services, and have them look it over. And the data and the facts will probably be there that it is needed and laws need to change. And if a syringe service program at this moment in time, because of the political climate, is not possible, then at least legalize peer-to-peer distribution or third-party peer-to-peer distribution. Legalize the ability to give intramuscular naloxone as well as Narcan, syringes, sterile equipment from one person to the other without actually having a storefront syringe service program.
Thank you.
So I'm Hansel Tooks. I will identify now as a harm reductionist physician from Miami. I just want you to know that it is possible. You can legalize syringe services in your state. It took us 10 years to get them legal in Florida, but with tenacity, we were able to do it. That was the same year that we made syringe services legal in Georgia. So you need to build a coalition of stakeholders, including people who use drugs, to inform you. Physicians, your medical schools, you need to have your deans, your medical students everybody will listen to medical students. They might not listen to me anymore as a professor, but they listen to medical students because they will take care of them one day. You need mothers who have lost their kids to overdose. You need to build a broad coalition, and you need to go to the Capitol session after session until you pass your legislation. And if we could do it in Florida, given the complex politics, I'm sure that it can be done anywhere. So I just want you to know that first. What's happening in West Virginia, I've told many of you today, I really, really feel for you. Syringe services programs are a way to deliver compassionate HIV care. I want to say one thing from the beginning. I heard a few times today that people who inject drugs may not be able to take PrEP or may not be able to take medication. That is absolutely false. I'm a physician who takes care of people who use drugs. People who use drugs are very good at taking medication. So I would like to put that on the record. So if we're able to leverage the trust of syringe services programs in places where they're authorized to do diagnosis through opt-out testing in order to offer rapid entry into HIV care, to provide support through peers delivering medications with syringes, with naloxone, building upon the decades of evidence of harm reduction programs and adding medical care to it, you will also be successful in ending your outbreak. But 30% viral suppression is horrific. I was shocked. I'm still shocked even saying it out loud when I heard that today from the commissioner. You really have a lot of work to do. And obviously I see things are moving in the wrong direction here, but continue the faith. I know that it seems difficult. It seemed difficult for me for an entire decade, but one day Governor Ron DeSantis did sign the Infectious Disease Elimination Act. So I promise you that with tenacity and passion, you will see this through.
One for Florida.
Thank you so much.
Hi, I'm Tricia Christensen. I work with Community Education Group, and I'm like looking at my boss, like I think she's gonna be okay with what I'm about to say. I've spent several years working in harm reduction as well, before and during my time with CEG, and I've been sort of racking my brains of like, what can PACHA do about all of this? Working in the Appalachia region has been eye-opening. I feel like every day I'm having meetings with people like who we met today who are doing amazing work and like they're doing such innovative things, they're so passionate. And my question for them every time is, what's going on with the politics? Like, what can we do here? And that's in almost all of the 13 states, right? So what can PACHA do about that is the question of the day. I think for number one, I was really happy to hear that Dr. Hansel Tooks is on the PACHA committee, and I would love to see more folks who are representative of the harm reduction backgrounds, more folks who are representative of local and regional organizations from across the country. I heard there's a lot of folks that represent like coastal cities. That's great. Y'all are doing great work, but it's not representative of the whole country. So really thinking about how to be more geographically representative, topic representative as well. It's not new to think about people who use and inject drugs in the HIV world, but it does still feel like sort of pulling teeth to have that conversation. I was really glad that Chris mentioned that smoking supplies hadn't been brought up once today, because I do think that's sort of like another path forward. Like we can talk about syringes all day and the political constraints around syringes all day. Smoking supplies is also incredibly stigmatized, but it is true. I did a lot of work in Baltimore when we were able to start passing out smoking supplies. People reported they were injecting less, right? They were either quitting injecting or injecting less frequently. So that is a harm reduction approach to HIV prevention. So really trying to think outside the box here. As you know, HIV, I think probably 10 years or 30 years ago, we thought it'd be over by now, and it's not. It just kind of keeps changing. So how can we represent more and more voices on the PACHA committee in the other federal representation?
Now I'm on. The viral load suppression rate that you quote, the 30%, we were at 30% 2 years ago. And now the most recent data that was presented at the rollout of the stakeholder plan 2 weeks ago, it was mentioned that in Cabell County, their viral suppression, and just in the outbreak of their individuals was at 40% viral suppression. In Kanawha County, it's 56% suppression, which I think is reflective of the 80% viral suppression that we have on our mobile unit on the west side. So while there's still much work to be done, the rates are better than they were. And overall, in our Ryan White program, of the total number of people that we see, 85% of them are virally suppressed. So a little bit less than the national average overall, but still good. But certainly in the outbreak population, we have a lot more work to do, but it's a little bit better than 30%.
Duvia Lozano, Chicanos por la Causa, Latinos Unidos contra el SIDA. With regards to the harm reduction strategy, I just wanted to mention that not only does it take the tenacity to continue to change those laws, but even once the law is changed in your state, it does take a change in culture. Sometimes the culture does not accept those clean needle exchange programs, right? And that is some of the things that I have personally dealt with in our state, in the state of Arizona. The Latino community is a community that is not very accepting of syringe exchange programs. It has been legalized for 3 years in our state, but the community kept pushing back. We don't want this in our community. It's going to have negative repercussions. So we just kept pushing and pushing and educating people, bringing people on board. It did take many, many months, but now it is successfully implemented. People are getting used to it. People are very happy that it's there and people have embraced it. So I just wanted to mention that also culturally, we have those barriers to break down, right? The stigma continues, but I feel that as Dr. Tooks mentioned earlier, with that tenacity and with that prevalence of, educating the community and making them aware of the pros of having these very important programs in our community, we will prevail and we will make our communities a lot safer and a lot better. So that's the only thing that I wanted to add.
Yes, when I have one more thing to that, a lot of you all have like given advice of what we can do at the federal level. Just want to remind you that things happen a lot quicker at local levels, and things are we're able to see changes a lot faster at local levels. And so I want to employ everybody here. I've seen quite a few of you who would make great politicians is to organize together and run for office. That city council vote, I think it was like 9-17 or something like that. It might be time to get some of them up out of here and organize together and get more people registered to vote in your communities who you're already helping them to figure out an address that they can put on their voter registration card, and going from there and just getting those votes out and putting yourselves up to take control and be in positions of power so that you can see those changes happen here locally.
Wonderful. Just want to make a couple comments about the harm reduction. Huge believer in harm reduction. So on behalf of the state of Rhode Island, the opioid settlement money, I think, is a huge conversation starter for states. I sit on that committee in Rhode Island. In Rhode Island, we have $192 million over 18 years to disperse. I learned today for West Virginia, they have $1 billion to disperse, and understanding that may be a piece of the puzzle, but I think it opens up conversations. As an example, in the state of Rhode Island, we're using part of that money to fund a safe injection site in our state. And so we have champions in our state legislature, our city council. It really has been that community effort. And champions was really one of the key things that came to my mind, champions in state legislature, in the community, of course, to push these issues. But I think it is a conversation starter as we talk about the opioid settlement dollars. It's funding for organizations. I heard a gentleman on the screen today was talking about more funding. I do think the opioid settlement dollars should flow into the communities, ideally. I understand there may be challenges for that. And I think that we have to hold, as a community, and what we're trying to do in Rhode Island is hold people accountable, right? $1 billion is a lot of money. So I think it's important to hold folks accountable, and that money should be going to harm reduction efforts, the opioid response, et cetera. So hopefully that is a conversation starter. Hopefully it pushes people to talk about it and to start addressing these issues. And hopefully there's some momentum to address these, especially in regions like West Virginia. Thank you.
I would like to add to his comment. Alabama got $250 million from the opioid settlement fund. I'm going to the first organizational meeting on the 28th, but a lot of harm reduction advocates across the country are worried about misappropriation of funds, and funds going to things that are not necessarily useful. Now, I did read the rules of how the funds are supposed to be dispersed. I believe 85% of funds given must be for the abatement of overdose and harm reduction education. However, there have been some states that have been able to sidestep and have been able to use funds very loosey-goosey. And so I want to see, the point I'm trying to make is I want to see the funds go to something that is actually useful. Actually will do something for the community besides, and don't get me wrong, I'm a full proponent of Narcan and naloxone. Give it to everybody. Put vending machines on every corner with safe smoking supplies, safe injection supplies, everything. But we need to be able to get it to everybody, not just people who are first responders or anything like that, just everybody, everyday people. And we need the funding to do that. And I'm hoping the opioid settlement funding in Alabama, I'm hoping that the oversight board will have some push in the legislature to actually change the laws.
Thank you. Give it a moment to catch up.
Hello. There we go. This is Trisha again with Community Education Group. Hi, Lucy. I know we've spoken before. I'm so glad that you're going to be attending the first Alabama meeting. I think Alabama, like West Virginia, is sort of just now starting to organize their opioid settlement distribution stuff and figure out how they're going to be handing it all out. 85% of the funds has to be used for opioid remediation. And that's like the exact language from the litigation. And the problem with that language is that it gives you advantages and disadvantages, that it's very broad. So to your point, it could be used for evidence-based public health, harm reduction, treatment, et cetera. It could be used to give to police, law enforcement, first responders for a variety of initiatives that I have opinions about, right? That are more or less effective. And that's where it comes down to this political process. It's so hard because I know what you're going through in Alabama. I live in Tennessee. I talk to people in West Virginia every day. I mean, it is rough to do this advocacy day in and day out and just feel like you're not hearing anything. Dr. Chen, Rhode Island is doing such great things. I'm always like, Rhode Island is great. Rhode Island is this tiny little state that is somehow like coalesced around harm reduction, and I love it. And I also feel like other states are not paying attention. So like, where's Rhode Island, right? They're not paying attention at all. But I really hope that y'all can pull out so much data and good information that can start spreading around. What? Dashboard. To remind everybody, CEG runs the Appalachia Opioid Remediation Dashboard, where we have been tracking how the 13 states of Appalachia are managing and spending their funds. So this is at the county level, the city level, and at the state level if they have this kind of like statewide commission. Happy to add anyone to our listserv, come chat with me. But the idea there is that we wanted to bring information right away about what conversations are happening. So even though in West Virginia, money hasn't really been spent yet, there have been a lot of conversations about how money is going to be spent. We've been hearing that a lot of counties are planning to use at least a portion of their funding to pay off their jail fees because they can do that in West Virginia. West Virginia's rules are a little bit looser than other states because they weren't part of the national settlement. But even in other states, they're talking about, they've talked about in Pennsylvania and some counties buying, hiring on law enforcement officers to do narcotics investigations. And as a part of that hire, that would involve buying them computers and bulletproof vests and guns. So luckily, there's been a lot of these examples that I think have already been squashed because local advocates, local media has come out and been like, is this an appropriate use of money? But that local media does not exist everywhere. I know it does not exist in a lot of West Virginia and a lot of Alabama. Those local advocates are burnt out, underfunded, as we know, as we've heard today. So it is kind of a continuous reminder to folks of what the spirit of those opioid settlement dollars are. It is essentially retribution or for lives lost, right? And so it really should be going to people, communities who have lost loved ones. And unfortunately, the process is that it's going through the government systems. So that means it comes back to the political process. So to your point, voting is important, right? Bringing people out, all those basic features, and all of that takes time and money and effort.
Thank you. Yeah.
And I'm still there.
For the whole community. I'm surprised that we did not hear anything from any of you in West Virginia about the Ryan White planning process, about the state HIV planning process, about the ending the epidemic process. I'm just surprised. Is there anything we should know about how that works and how it's going?
What you may or may not know is that West Virginia is a part of 2 Ryan White processes. So we're a part of the Washington, D.C. We're part of the Washington, D.C. EMA, some counties, and then some other counties are a part of the Ohio EMA. There are 3 counties, Morgan, Berkeley, and Jefferson. Do I have that right? Right? That are a part of the D.C. EMA. And then there are other counties that are a part of the Ohio EMA. And so it is challenging. Christine just turned around. There's just 2 counties in the Ohio. Yeah, Ohio, sorry, Berkeley, Jefferson, and Morgan. Is that right? Do I have a Berkeley, Jefferson, and Morgan are part of the, get the cash, but Berkeley is also a part of it technically. And so I think it's all, and also in order to participate in the Ryan White EMA for DC, you have to participate in DC or you have to participate in Ohio. It's not like they're here. Huh?
So, is it my turn? Yeah. You know, I do think, I'm sorry.
Comment, go ahead.
I actually want to go back to the settlement question, because I think personally, I think, you know, the Ryan White dollars that will flow through here are limited because it's based on a case count, right? In addition to many other things. However, the settlement money is huge, huge. And, you know, thinking about where are the efforts to get the most resources in here, that's huge. But I'm wondering if there is and I hear you about where it's going to be appropriated and is going to be appropriated to law enforcement and prison and like all that nonsense. But so I'm wondering, as PACHA, is there some national overseeing body, or is it at every individual state level? I'm asking. I'm sorry, I don't know your. I don't remember. I'm sorry, I don't know your name. Tricia. I'm asking Tricia.
Local opioid settlement expert. So every state, the money is funneled through states. Each state has created their own sort of structure plan, and then it varies from there. So I will say in every single state, some amount of money is going to counties, and it might not be every single county, just depending on size and all of that. But in some states, that's like 15% of the money. In other states, that's 85% of the money. So depending on the state that you're in, it's important to know who is the main decision maker for those large pots of money. West Virginia, I want to say it's 72.5% of the funds is going through the West Virginia First Foundation, which is what they're like currently setting up, that Dr. Christensen is a part of, and they're like still they're over a year away from distributing funds for sure. And then a small percentage is going directly to counties. It's a lot of the counties they're the ones who have been talking about how to use their money. Many of them are probably going to use it however they want, not necessarily to the spirit of how advocates think they should be using the funds. But again, that's sort of where the advocacy comes in. But there are the rules about that 85%. The unfortunate piece of that is that this is not congressional money. There is no congressional oversight of how to use those funds. Technically, the requirement is they have to report up to the legal people if they spend more than 15% on non-opioid remediation. But because it's not, like, why would they do that? Why would they report, tell on themselves that they're doing this wrong? And even if they do tell on themselves, what are they going to do about it? I think theoretically, the people paying the money, so pharmaceutical companies, could withhold funds, but I don't know why they would do that either. They want this all to go away, right? They don't want to talk about this anymore. They just want to pay their settlements and get out of the conversation. So those reporting requirements at that level are very poor. Different states have set up different reporting mechanisms themselves. So that's another advocacy consideration, is how to encourage states to promise to publicly report how they're spending their money. I'm also very interested in the reporting at a detailed level. So they might say, oh, we're giving $1 million to this organization for OUD treatment. I want to know, does that include medications for opioid use disorder? Or is this a abstinence-based program that we don't really know how effective it actually is? And those kinds of details are going to vary state to state in how they decide to collect that information. In some states, the AG's office is very involved, but I think it also still kind of depends state to state. So the AGs, they are the ones who are kind of managing all the litigation piece of it. So they might be involved in some of this oversight. But again, I think in some states, they're not really necessarily. They're just letting the counties deal with it, or they're letting the governor deal with it. You have to figure out in your state who the decision makers are and who really has that power.
I was just going to try to answer that Ryan White Planning Council or plan issue. So in the state of West Virginia, Ryan White funding, there is Part A dollars that flow into Berkeley and Jefferson counties in the Eastern Panhandle from the DC EMA. They do, as you know, have a large planning council that meets at least quarterly to talk about the plan and implementation of their their dollars. There is, to my knowledge, there is no other Part A EMA funding that flows into West Virginia. There is the state Part B program, which funds the AIDS Drug Assistance Program, which is now primarily insurance premium, and copay assistance and ADAP for some individuals that are underinsured, some case management. There are 2 Part C programs, which that's ours in Charleston, and then there's one in Morgantown at West Virginia University. They also have a Part D grant for women and children that they got maybe 10 years ago. And then there is the AIDS Education Training Center that is funded through Ryan White that is in Morgantown also. And that is it in terms of Ryan White funding that comes into the state. There is no really formal planning group for Ryan White in the state. We did have, previous to this year, we had the groups would come together and provide the statewide coordinated statement of need every year. That Part B, organized Part B primarily did that. This year, for the first time, CDC and HRSA came together, and we have a state joint HIV and hepatitis C elimination plan that was developed and written just this past year, that was approved through the governor's office at the end of last year, and was officially rolled out to stakeholders a week ago at Stonewall. And it was a comprehensive process that we looked at the 4 pillars of prevention, diagnosis, treatment, and respond. And there were, I think, several hundred people that participated across the state in subcommittees that did that work. And then there were also 187 people with lived experience that either participated in online surveys or focus groups. And there were men who have sex with men were interviewed, heterosexual groups, and then there were a large representation from people who inject drugs. So that was a critical part of the planning process. And so each of those 4 pillars, there have been goals and objectives related around each of those things. And Dr. Feinberg touched on some of that this morning, but a lot of it has to do with education of providers, getting more people in primary care more involved in providing HIV care and PrEP. PrEP features predominantly in the planning. There is mention of syringe service programs and trying to increase access, but we've talked about the limitations of that and some of the barriers that we have. And then just ramping up our ability to provide boots on the ground with mobile units and community health workers, and leveraging other groups that are working with high-risk populations, such as health departments, quick response teams that respond to overdoses, recovery centers, and other people that have lived experience. So the next step, the plan's been rolled out. We will now be moving into the implementation phase. So we're soliciting participants into each of the 4 subcommittees that have developed the goals and objectives to actually come up with discrete steps that we can take it to the next step to actually implement and not just have the plan sit on the shelf. So that's kind of where we are.
Thank you. So we've got Mackenzie here, the individual online after him, and then, oh, here, I'm sorry. Okay.
Awesome. Thank you. I just wanted to add, while we're talking about the DC EMA, I sit on the Ryan White Planning Commission in town, and we represent Berkeley and Jefferson counties as well. And if there's anybody here who would want to talk about either the steps that we can take to put more money here, perhaps, or even membership onto that council, I would love that. And it would be really awesome to put some faces to a region that we've been representing without having conversations with for too long. Thank you.
Mark, can you hear us?
Yeah, I can hear you now. Can you hear me?
We can hear you.
Jesse, thank you for bringing up the Ryan White Planning Councils. One thing that I've missed during the conversations of both the sessions that I've been attended is consumer involvement and the importance of that. I live in Maryville, Tennessee. I look out in this new Appalachian Mountains. See, like Buttertown, Happy Heart, all those towns that we don't hear a lot about. So it was brought to my attention that from Chattanooga, Tennessee, to basically from Georgia to Virginia, we have 2 regions, the Southeast, the Southwest region, and the East Tennessee region. There are 3 positive people sitting on that council. That is, in my opinion, a crying shame. There needs to be more involvement, and it would be nice if there would be ways of studies or someone could reach out to people and educate us on more ways to involve the community, because a lot of your answers are sitting there in the community. So the importance of the Community Planning Council, in my opinion, is at the local level. It's where all your decisions are made. I look on here, there's 10 participants nationwide joining this. So any help that the government can offer in regarding to recruiting community members, and especially those people living with HIV in the planning council, would be wonderful. Thank you.
Hello, I'm Cassie Province. I work for the Covenant House. I do HOPWA for 22 counties, the southern counties here in West Virginia. I am one of the 2 case managers. We just got 2 case managers last year. I did it by myself for 3 years before that. So our outbreak has hit very hard. The year that they separated Huntington, which Cabell County and Wayne County, the year before that, we also had them counties too. They got their own HOPWA because of the outbreak. So they got their own HOPWA situation going there. They only help the homeless. They do not help anyone else living with HIV or AIDS that isn't homeless. So the ones that aren't homeless come here a lot because they know that they can get help from us. We just got granted $350,000, which is great. Don't get me wrong. When I first started, it was 170. So we're moving up, but we're moving up because it's formulated. So it's formulated by the people that's affected, the people that's living with HIV and AIDS. So in our jurisdiction, our barriers, our huge barriers, of course, is available housing. Y'all see how little we are? You can only imagine how few landlords we have. Okay. So the more southern you get, the more rural we get, the way less landlords that we have to work with. Housing people who are actively using IV drugs it's not impossible. It's absolutely not. I've done it 100 times. But it's hard. It's hard to keep them housed. It's hard to keep my landlords out of their business. It's hard to explain why I'm housing them and why I pay all their bills and why I do all this stuff without getting 99 questions. I waited until the camera was off so I could talk to you. So my face isn't all over the West Virginia news as helping people with HIV and AIDS because it has to be that way. Some of the barriers with the harm reduction, and everyone keeps telling y'all that we have laws, but they're not telling you what they are. So for my client who is living on the streets to get clean needles, they have to get an ID. To get an ID, you have to have 2 forms of a proof of residence. I can't even use my address anymore at the Covenant House where we used to use, which would use perfectly. They won't let us, the DMV won't let us do it. So it goes up to the top. So the DMV won't even let us get their IDs. So then we have to come around a million different ways and come up with all these different ways to figure out how to get their IDs, how to get their birth certificates, their social security cards, the birth certificates to get that. This is 4 weeks process. And that's if they're from West Virginia. If they're not from West Virginia and I have to order one from, Lord, please don't let me have to order one from Texas because it takes 6 months. But if I have to order a birth certificate, so this is how long they have to go without clean needles. And then I get the needles, or I get their IDs and I get them housed and I get all these things and they go in. And so they come to us for 20 minutes and get their medicine once a week. Or they might, get their medicine refilled every 3 months because they've been in care for a long time. Then they have to go in and they have to sit and they have to talk to another harm reduction specialist for 2 hours just to get the 30 needles that they have to bring all 30 back to even get more. So it's one-on-one. It's the biggest barrier. It's the hardest. So then we get people in care and we get them great. And even if they are still using and we get their undetectable and everything's good, but then they get endocarditis because they're still using dirty needles, so then we're losing people, not from HIV, but from drug related illnesses because they can't get clean needles. So it's like we do our job and I've literally pulled a child. He was 19 years old when I first got him and I pulled him out from underneath of a house to HIV test him. At that point, he was negative. 3 years later, he's now positive. He's heavily, heavily addicted. I'm talking 3 to 6 grams a day. Okay. Heavily addicted. But the medicine works and we got him on this bus and he was undetectable within a month. And it works and he comes every week and he comes because we have incentives and he comes because he knows we're coming. And so just yesterday, I'm like, you got your ID, you can go get clean needles. And he was like, but I can't go right now. I can't do that right now. I gotta go, it takes too long. It's just the walls are just up so hard against us sometimes that it's insane. So the more leveraging y'all can do for us, of course we applaud it and we need it. And I just wanted you to hear from from somebody who, I mean, we're in there. And y'all seen us out there yesterday. This is what we do every week. That we didn't do that just because y'all were here. This is something that we do every week. And if I'm not at that bus, one of my peer support person will be there to go and get the people that are still getting linkage to care, because we do it for 6 weeks. 6 weeks, I'll bring them down there every time I have to. And then, but I'm covering 22 counties and there's only 2 of us. So sometimes in like Mercer County, we have a big, just kind of a pop-up testing event, and that's Southern. That's very Southern. And we got this pop-up testing event come Monday, and I just got called on it because we have 4 new people with HIV down there. So, but that's an hour and a half, almost 2 hours away from me. I'm the only case manager that can get to go down there. So housing down there, they don't have any. They don't have low income housing. So it's just, I mean, just to get a little feel of what it really is. I know everybody told you about it, but it's serious, and it's every day. And these are people that we put in, and I say we because I'm sitting here with Ryan White, because we work hand in hand all day, every day together. And it was crazy. I did go to the DC convention, and to learn that other people don't, other HOPWA and Ryan White don't work together. I was like, I don't know how y'all do that. Then where do you get your statuses? What are you doing? Like, how do y'all do that? So it was very weird, because since I've started, that's just what we've done. But I mean, these are people we care about, you know what I mean, that we can't get the services that we need to get. And mental health is huge on this. We have so many.
Almost basically a time. So
okay.
If I could just
no,
ask you
you're
to
fine.
wrap up, that'd be
No,
great.
y'all can have the mic, but mental health services, please. And I'll be talking to you.
Thank you.
So I'm going to make this extremely quick because I heard I have 30 seconds. My name's Teresa Galloway. I'm the assistant director of the Healing House. Hey, friend, how are you? So Dr. Hansel said something earlier that I didn't feel was answered correctly or answered at all. And so I wanted to answer his question. And he said that there was a myth, or how do we deal with individuals who may seem like they never want to recover, or they're just fine with using. I will tell you that one of the services that we offer at the Healing House is support groups. And one of the things that I consistently ask my ladies that come to those support groups is, how do you feel about being sober? And one of the answers multiple answers that I got around this question was, I am terrified about being sober and sobriety, because last time I was sober and I had a bad day, I didn't know how to handle that. Right. And so I think that speaks volumes to the resources or lack of resources that we get for organizations like the Healing House, because one of the things that I think falls through the cracks is the one-on-one, the ability to be able to see people exactly where they are and exactly how much hurt they're in. And if we cannot educate people on how to cope properly in the situations that they are in, then we are going to be in a cycle of, let's do all of this reactive work instead of this proactive work. And we're going to never see change happen in West Virginia. So I wanted to answer that. I answered it for him earlier. But there's a perfect example of this. Not even 2 weeks ago, we had a young lady that came in. She's been in recovery. She just got out of jail not that long ago. She got pulled over by an officer and she didn't have her driver's license. Why didn't she have her driver's license? Because she didn't have documentation. And in order to get that documentation, she would have had to go through all these steps. Well, another part of that was she had to retake her driver's license test. And she was terrified about it because she has a lot of anxiety. And so when she got pulled over, she thought immediately she was going to go to jail. So I called her PO and talked to her PO and told her, please don't send her to jail. She is really trying to do all the things correct. She's been compliant in our organization. She's been compliant in our programming. And I don't want to see her go back to something that she worked so hard to come from. So long story short, I helped her balance her bills, made sure that everything was on a payment plan so that she was not overwhelmed. She came in saying, I feel like I'm going to relapse today. She was 2 weeks away from 1 year sober. We bought her cupcakes to celebrate her 1 year sober. She made it. And I believe that she made it because of the intervention that we had with her that day. So I am here to tell you that harm reduction is beautiful, and I do believe in it, but harm prevention, in my opinion, should be what we focus on.
All right, let's continue on with the next portion of the agenda. Ada, you wanted to share something?
I just want to share something with you all. Thank you so much for your participation. That information, the notes that we have there, we will be taking that back. So it was not just given, and we will not be not taking action on it, we will be taking action on those ideas and things. So thank you.
All right, so now we'll move to PACHA discussion. We do have Justin would like to share some work that he's been doing on a resolution.
All right, so thank you all for the attention for a second. So as you know, we've been engaged in many conversations about HIV and aging over the last several years. So even as recently as 2 weeks ago when we were in DC for USCHA, we heard loud and clear that there needed to be some action taken on HIV and aging, and particularly the issue of the upper age limit of the CDC HIV testing guidelines. And so the Stigma and Disparities Subcommittee has worked on a resolution that we'd like to bring forth for the full council's consideration. That would essentially, the point of it is to urge our colleagues at CDC, as they're rewriting the HIV testing guidelines, to remove that upper age limit such that HIV testing is offered routinely to folks ages 13 and above, with sort of no upper age limit to that. So that's the gist of the resolution. It was sent out in the material, so if you all have your laptops, you should be able to pull it up. I don't think it's in the binder, unfortunately. It is? They just passed it out. Okay.
Oh, I don't know.
Okay.
Do we have additional copies?
Are there other copies going around the table? Because I don't think I have. I can pull it up on my computer too. So.
I don't have it.
It's not in the binder. So as those copies are making the way around, for folks that have not had a chance to look at it, we'll give folks a couple of minutes just to look at the resolution. The way that this process works for our new members is oftentimes when we do these resolutions, folks have a little bit more time to look at it, but obviously you're new, so you haven't had a chance to do that yet. And we do make sort of live line edits. So if we can ask our tech team if they have a copy of the resolution to pull it up on the screen. And if folks have any line edits or additions, that those can be made in real time. So John, I know you had a couple of line edits that you wanted to offer, so we can go ahead and take those while you pull those up.
Thank you. There were just a couple of things that I think needed to, and very minor, like typo corrections. So early on in the document, in the initial paragraph, you have healthcare as two words separated by a hyphen, and then later on you have healthcare as a single word. I just thought we should be consistent with that. I would have to look. There was something else.
Yeah, I think we can do a one word.
Yeah, so one word.
So then if our team can, looks like it's line 8. So at the end where it says healthcare, just delete the hyphen. I think that, perfect. Okay. And you had one more, John?
I'll have to find it.
Okay.
I have a little typo.
Yep.
The stage 3 disease, and then in that next line, it's just should be so it's line 18 and 19.
Yep.
Capital S for stage 3 and small s for stage 3. So one or the other.
Okay.
Capital.
Sorry.
So the
so awful. Capital.
Oh,
capital on both?
Capital, yeah. Capital both, yeah. Yeah.
So then in line 19, just to make that a capital S.
It's done.
I just want to ask for a point of clarity on line 19. Should it read stage 3 AIDS or just AIDS as indicated in parentheses on the previous line? Or stage 3 disease again?
So I guess for consistency, we should say stage 3 disease.
With AIDS in parentheses.
With AIDS in parentheses, just to kind of make the consistency. So thank you for that. Just wait for our team to check. Cool. Okay.
Somebody already pick up 22.
Paul?
Just a question. Do we still have our CDC person on remotely? Because the question that I would ask them is this still, like, are they thinking about changing this, or where are they in this one?
So based on a conversation we had at the previous meeting, they are working on updating the guidelines. So, and we acknowledge that in sort of line 32. So, yeah.
Question?
Yeah.
Just to clarify for the be it resolved, it's to be clear that you would be recommending that HIV should be performed at least once as part of routine healthcare for all individuals age 13 and older. Is that what you're advocating for? It doesn't say the frequency for the routine testing. I would just, I think, be clear. It sounds like the same wording as what the CDC is saying. So at least once as part of routine healthcare. Is that what you're?
So I think what people are asking for is that it should be offered routinely to people, regardless of so basically that if it's just, I guess in the weeds of it are that for people that are deemed at higher risk, there's sort of more frequency of recommendation of when testing is offered. We're trying to sort of not get into the weeds of that, but just to say that CDC should recommend testing for people 13 and above, period. So does that answer your question? So
yes, I guess the way that I read the current CDC recommendations, right? If someone comes in at the age of 75 and has never had an HIV test, I would advocate, yes, we should test them, right? At least once. And then it should be a risk assessment about how frequently to test them, and maybe not again if they don't have any ongoing risk factors. So I think the way that it's written at the very end here is just, it's a little bit confusing to me.
Okay.
I'm just seeing it for the first time, just in terms about frequency. And to your point, totally agree. More risk factors, they should be screened routinely. I think I would just keep that in mind.
So we'll do Jesse and then, yeah.
I think the current CDC recommendations, which this is in response to, is that all individuals 13 to
64,
be screened once.
Right.
And this is to say that recommendation should be changed to all individuals 13 and older.
Yes.
Right. So it's not, I mean, obviously we would like to have it more involved and about frequency and all that, but this is in direct response, I believe, to that current CDC recommendation that says at once, for all individuals between 13 and 64.
Once a year or once?
No, once in a lifetime is the current recommendation.
Which I don't really like that recommendation.
Yeah, I don't think.
Yeah, I think it's at least once.
I think it's yeah.
I think it's at least once.
No, it's not. Well, once, at least once. It doesn't say once a year. At least once.
Number 11. Look at sentence 11. Undergo HIV testing at least once.
Yeah, for heightened vulnerability.
Okay, folks, if you can please put your cards up.
If you have a card. Yes.
So Ada.
So again, and I appreciate Phil pointing this out, and I had pointed it out initially when we were discussing this. I think we need to put what the CDC recommendation is and frame it in that way. So we'll change this particular sentence to what we did in paragraph in the first, in the second, performed at least once as part of routine health care for individuals between, so change
just
that.
Mirror that language.
Exactly. Use the same language.
Yeah.
Thank you.
Yeah.
Okay, next we have Patrick.
That was my point, that it's at least once per year unless people have other risk or at least once per lifetime. So I just wanted to clarify.
Great. So Ada, on line 9, Ada was suggesting that we mimic the wording that begins HIV testing should be performed at least once as part of routine health care for all individuals 13 and older.
And further
recommends that people at heightened vulnerability to HIV acquisition undergo HIV testing at least once a year.
So you'd like that entire
Yes.
remaining sentence duplicated at the bottom?
Yes.
Justin, are you comfortable
with that?
Great. We will make that change.
So can you repeat what the changes going to be? Because I didn't begin to hear.
Yes. So if you look at the second paragraph that begins on line 8,
Yes.
the entire sentence from line 9, from the words HIV testing to the end of line 11 will be duplicated at the end, beginning on line 36.
Added to the resolve.
Yes.
Resolve. Good.
Yep.
It will replace such that HIV routine testing is offered to all individuals 13 and over.
No.
I think we'll keep the such that, and then so
Okay.
each state 20 and over. I think it's just trying to,
yeah.
It's that first part about performed at least once as a part. It's the first clause.
Taking out the 64 part.
Yes.
Yeah.
So
being older.
did I?
Yes, we're taking out the and 64 part.
Yeah.
So they're going to do these same
There we
things,
go.
but instead of
And
just removing
in line 9, it says and
Adding
64.
this part
to down
to
here.
the resolve.
Right. And so,
You go.
Yeah.
Okay. Looks good.
That was really, looks good.
Yeah, that's right. No, but it says, I'm sorry, line 10, 15, and 64. We just need to get rid of the and 64.
As a lawyer who loves this stuff, that would be.
Can you read it back for those of us that may not be able to see the final print?
what's that?
That's second part of the sentence is in.
What's that?
What's that?
Do you need it read? Okay. Be it resolved, PACHA recommends that CDC remove the upper age limit of its HIV testing recommendations when it releases its revised HIV testing guidelines, such that HIV testing should be performed at least once as part of routine healthcare for all individuals ages 13 and over, and further that people at heightened vulnerability to HIV acquisition undergo HIV testing at least once a year.
Thank you.
Patrick. So
Wait, can I make one more question that's more linguistic? But I was sort of looking at the current guidelines, and this language "undergo testing." Undergo usually isn't a good thing if you're going to undergo something. So I wonder if we could just keep the original language, which is for people with higher risk for HIV. CDC recommends getting tested for HIV at least once a year rather than undergo testing.
Sure.
I'm not sure. And editorially in line 12, that thereby isn't necessary. Should just be, it's an extra, just be necessitating a comprehensive.
So
Thanks.
So take out the thereby in line 12.
It's more grammar than
Hmm?
Okay.
Yeah, there's 2 places where it says undergo. Or I would just say get tested for HIV. Yeah. Line 11 and line
22.
Well, you can't change what the CDC.
Sure. And then the one again later.
Not 22.
You can do whatever you want. It doesn't.
Yeah. You can't change the language in that one, right?
No, that's right.
Hold on.
Yeah.
38.
Yeah. And what is your suggestion for the verbiage you want?
Get tested for HIV or receive HIV testing. Just
Receive. Yeah.
Receive.
HIV testing for undergo. Thanks.
Yeah, that's good.
But you can't change the language of their
It's the
current
original language.
recommendation.
Yeah.
What's that?
So you need to say what.
Yeah, Paul, go ahead.
No.
I wasn't fully listening, so I may get this wrong, but if you're suggesting to change line 11, you can't, because that's the actual language of the CDC recommendation, right? You can only change your recommendation. You can't change what their policy is, right?
I think that was what they're.
I think Paul is saying that is the language of the actual guideline or recommendation, but let us.
I see you looking it up.
Yeah.
Sorry.
We're up to, so.
Well, plus the lawyers. It has to be right.
That's right.
It has to be right.
Are you looking?
I mean, we could leave it that we should stick with the language. I'm pretty sure that the language is, pretty sure that is the language, but we
So
could just leave it. We would stick with, we're going to stick with the.
I'm on the right page.
Give
now.
Justin just a moment.
change what you recommend, but you can't change what
Okay, so where is there's like some summary statement.
I'm just going to search this document for undergo.
So that,
Yeah.
There it is. Okay. Performed. That's the language that they use. Performed routinely. Yeah. Yeah.
But on line 11, it says perform. That doesn't automatically work.
So that'll be on line 11. We change undergo to perform.
That's what it says.
Perform.
That's what if we're trying to mirror the CDC language, what it says in all healthcare settings, screening for HIV infection should be performed routinely for all patients aged 13 to 64 years. So,
No, and then at the end of that, HIV acquisition undergo is the word that he was proposing to change. What?
So we're looking at
Look at line 11.
Line 11. So
We do have a tit up. Adrian, please.
Just a quick clarification that might answer some of the confusion. So what the current guideline is it's correct what you found, that the current guidelines once in a lifetime, but what CDC is working on right now is actually a review on that part of it. I'm not trying to tell PACHA what to do, but they're currently reviewing that piece anyway. They're doing a scientific review, and that's what they've stated. So I just wanted to offer that as a clarification that the frequency is what they're already reviewing.
Yeah, right. Okay, thank you.
Yeah.
I think we can change that to because it's written differently in two different places. So like this is from the MMWR, but then on the website it has different language. So
Are you comfortable if we receive?
I think that's fine. I don't know. Yeah. So
That's why we can't do any resolution.
I don't have strong feelings about that. If other people do, so.
This is why we can't.
Yep.
Because it took us all this time.
Any other, Mackenzie?
I know.
What if we quoted and directly cited the guideline? Like with quotation marks? And then just be really clear exactly what they should change.
A word.
So that really is what it says though. So, I'm just trying to find the exact. Yep. Yeah, that's what it says.
All healthcare settings, screening for HIV.
So this is what it says on the website. So, okay. CDC recommends that everyone between the ages of 13 and 64 get tested for HIV at least once as a part of routine health care. People with certain risk factors, CDC recommends getting tested at least once a year.
I'm not going anywhere.
So I think that we're good. Yeah. Any other?
So we're changing undergo to receive.
So
on line 11, and then repeating that at the end in the result.
I think we can even just say get tested because that's what the CDC, the line I'm quoting from the CDC website. It says CDC recommends that everyone between the ages of 13 and 64 get tested for HIV at least once a year, at least once as part of routine healthcare. For people with certain risk factors, CDC recommends getting tested at least once a year. So we can just say getting tested. Yeah.
Yep.
Get tested. Yeah.
Thank you, Patrick.
May I offer another
Julia?
recommendation?
So on line 29 and throughout the document, it reads individual 65 and older. But if you look at line 30 and 31, you state age 65 and above. So can we keep the language uniform throughout the document to 65 and older?
Yes.
Thank you.
Good catch. Thank you.
It's 64 and older, right? Or because the current guidelines go to 64.
Raise your heart, Jeff.
Uh-oh.
So is there any other comments, additions, edits that people want to offer?
I mean, like there was a concern on 65, but the entire year of 64, they
Right. So they're 64 until they turn
until
65.
they turn 65. So I think 65 and older.
Yeah.
We good?
Are we good?
Are we good?
I am so glad to be back on the Federal Advisory Committee.
Yes.
Welcome.
All right. So unless anybody has any other edits that they would like to make, we could entertain a motion from someone to approve.
So I would like to put forth a motion to pass this resolution.
Second.
Thank you. We have a motion from Justin, a second from Jesse. Any further comments? All those in favor say aye.
Aye.
Any opposed? Any abstentions? So passed.
Thank
Justin,
you, everybody.
yeah,
So-
thank you so much for your work on this. I believe we had someone on virtually today from Sage USA. I know that they spoke to this issue. This has actually been brought to PACHA several times previously, and I'm really excited that we were able to take direct input from the community and put it into a resolution from PACHA. So thank you very much for that.
And congratulations to the new members for passing your first resolution at your first meeting. So.
Excuse me just a moment. I moved all of my documents around to get to that. So would you like to take over for next comments from folks? Jesse, I wanted to ask you had discussed something that you thought might be important to bring before PACHA for discussion.
Thank you. Thank you, John and Ada. Thank you so much. There have been 2 public letters recently from the HIV community expressing great concern about the failure of Congress to reauthorize the PEPFAR program by the current end date, which is September 30th. And then a second concern regarding the House Appropriations proposal to cut over $767 million out of the HIV federal portfolio, including some drastic changes to the bipartisan ending the epidemic plan, and also drastically reducing, and I mean drastically reducing, the Minority AIDS Initiative, and including some cuts in the Ryan White program that could include Part D, which include, or the part that includes funding for the AETC programs. It just seems to me that with PACHA meeting at this juncture where these 2 proposals are now happening, one from the House Appropriations Committee, and the second, the fact that the PEPFAR program is literally due to not reauthorize by September 30th, I think that we have to say at least something. And recognizing that the process for a resolution resolutions is awfully complicated for us, I'm wondering if we might at least have a sense of the meeting so that we can say to the Secretary and to the Office of National AIDS Policy at the White House that we are deeply concerned about both of those, and that because we do recommend and provide advice to the Secretary of HHS, and the Secretary has an Office of Legislative Affairs that reports to him, and their job is to work in collaboration with Congress, that vehicle, that arm of HHS can be guided by us in our recommendations to the Secretary. So I would urge that we say to the Secretary the sense of the meeting of this meeting of PACHA, that we are deeply concerned that PEPFAR has not been reauthorized. We urge that the Secretary do everything he can through his Office of Legislative Affairs to make sure that that reauthorization is a highest priority, and that reappropriating for the PEPFAR program is a highest priority, and that his Office of Legislative Affairs work diligently to make sure that the proposed cuts by the House Appropriations Committee to the HIV federal portfolio not happen.
Yeah.
And I'm going to weigh in here. Resolutions, and I've said this at other meetings among our members, resolutions is but one tool in our toolbox. There is another avenue where co-chair McNeese is not here, but our co-chairs that are serving today can pen a letter to the Secretary and said that PACHA met on this day and of concern, and do similar bullets. I mean, we can, pull the record. And that can be a letter. I mean, the group would still have to do a vote if that is the will of the group, because anything that moves forward is the will of the group. But if that is it, it does not have to be a resolution. There are other avenues to move forward action and recommendation. So I just provide that as guidance.
That may be a very expedient solution. And I applaud you, Kay, because I know you know how you guide us so well. But with 150 CEOs of national organizations and regional organizations signing that letter, including many of us around this table, I think this moment cannot be passed. For PACHA to not say something, we really must say something, and we need to say it quickly.
So, okay, in terms of that, with Ada and I both rotating off at this meeting, would we still be able to send that letter, or would that require another meeting to discuss? Like, what will we have to do there?
No, it doesn't require another meeting, because you have a body and quorum here to do that work, because it is going to be an action of this meeting and this convening. What you would have to do is actually come up, if it's 3 bullets. I mean, Jesse kind of eloquently, and so our note taker may have captured all of that. Dana, if you're on the line. So there are a couple of, I heard like maybe 3 or 4 bullets that would be the guiding sort of, if you will, guiding guidance for that letter, because it can be very brief, but it's that PACHA convened on said date in West Virginia at the 78th meeting. These were issues of critical concern, blah, 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 signed. But you guys as the voting membership would have to vote on what those bullets are, and that was the will of the group.
I think it may be important to point out also that the Minority AIDS Initiatives funds supports the Office of Infectious Disease and HIV Policy at HHS. It supports the staff that oversees PACHA. And I think that change could be a drastic change to the ability of PACHA to actually operate if those funds are reduced. So this is very important.
I was going to ask Jesse, is there any way that you can
write up what I just said?
Yes, please. Thank you.
Already did. I'm looking at it.
Yeah, if you've got that, that's great, Paul.
Yeah, 2 things, Jesse. Can we make sure to add a piece about the riders, because we need a clean passage of this legislation? And what I mean by that is, right now the Freedom Caucus has 40 different riders added to the HIV bill that include riders like against transgender care and all of these really awful riders. And so we also need a clean bill to pass. But probably this is the second thing that I wanted to really ask when I first raised my hand, which is it possible for us to get an orientation? You have a lot of new members this time, and we don't know all the rules and the responsibilities or all the different vehicles And so it would be really helpful for me to kind of have an orientation. I appreciated the ethics orientation, but it's more of like a general practice. Like, how do you do things? What's the different kinds of ways that we can communicate? And for us to be able to ask kind of questions that we may be embarrassed to ask in a public forum about kind of what is appropriate and what is not appropriate, because I don't want to do anything that's inappropriate, and I often do. And so I know I get it. Yeah, you love it. The feds hate it. And so I would just like to make sure that we could have an orientation at some point.
No, that's perfect. We do. And as you were just sworn in about, I don't know how many hours ago, that is part of it. An orientation. We talk about our subcommittees that are existing. Perhaps there are new subcommittees on the horizon and what those look like. So this was just your day one, a couple of hours after being sworn in by Admiral Levine this morning. So yes, our orientation is part of that, sort of the nuts and bolts and do's and don'ts. I'm often reminded, you guys are not funders, those kinds of things. And so, those are the kind of things that will come up in an orientation. Jesse said it so eloquently. You guys, and it's in the charter. I'm always like, look at the charter. You have any questions? Look at the charter. But you advise Admiral Levine, Secretary Becerra, and then we also provide everything to Harold Phillips, Director Phillips at the White House. That's our wheelhouse. So I just say that as, we will cover that more in depth in our orientation and opportunities about subcommittees that you will each be on at least one. But yes, so short answer, Paul, yes.
So then we would need a motion to approve sending the letter based on the draft supplied by Jesse with I assume we'll need an opportunity for PACHA members to review it rather quickly as well for feedback before we send it. So I'll need a motion and a second for that. Carol? Thank you. Second from Paul. All those in favor say aye.
Aye.
Any opposed? Any abstentions?
And do we have any members that are still online virtually? Okay, hearing none.
Jesse, thank you for pointing out that important information, and I'm glad we're moving forward on that. We now have a few moments for PACHA members to reflect on the visit today, or offer any words that they would like to say as they move on from their membership. Paul?
Let me say, first, I just want to say thank you. It was, for me, it absolutely exceeded my expectations of what we were going to be doing here. And to the people from West Virginia, I really want to say thank you. This was typically not a state when it was 97% white that I would have come to. And so to be able to meet so many powerful women of color in so many important positions in all of this work has I am rethinking everything that I was going to say about PACHA, and I really appreciated that opportunity. I didn't mean it in a bad way. You all look at me like, but I mean, I think we don't necessarily always understand until, and so the PACHA-to-the-People thing, really good. Congratulations.
Thank you. Justin?
So to our colleagues from West Virginia, thank you for welcoming us into your home and to sharing your passion with us and allowing us to see so much of the good work that you're doing here. It was really deeply inspiring. And I'm just happy that this was my final meeting to be here, to be inspired, to feel like the ship is going to be steered perfectly by the new class of folks that are coming in to PACHA. I am excited to be passing on the baton to such an amazing group of leaders. So I just feel very full. It has been such a deep honor to serve my country in this capacity. And so I leave with just a lot of gratitude, and I am not going to be, gone. So I'll still be in the work with you all, just from a different standpoint. And I'm just excited to continue the work together, because if we're going to end the epidemic, it's going to take all of us to continue this work. And I'm just excited for what comes next. And I am just, I'm really sad I won't get to work with you all on PACHA, but I'm excited that we'll have other ways of collaborating, because this is family, so we say at PACHA, once you're PACHA, you're family forever. And I am really excited to see what this next generation of leaders, especially some of my younger brothers that are joining. I'm just so excited that y'all are around the table. That's really just amazing. So thank you for allowing me to serve, and I look forward to what comes next. And I'm always a resource. So, Paul, you said if you have questions about how PACHA works, I'll give you my number so you can call me anytime. And that goes for anybody around the PACHA table. And I'm just excited to see where you take this council. I think we did a lot of really great work over the last 4 years, and I'm just excited to see what comes next and what you all bring and make possible for this field. So thank you all. And I just want to give a special shout out to Kay, because you just make everything possible. And to Caroline, this has just been such a joy to serve under your leadership and just keeping the guardrails on all the time. So thank you so much. And to my colleagues that are rotating off with me, it has just been such an honor to get to know all of you. This has just been a wonderful experience. So, and to the folks that are staying, I'll stop. I just think that this has been such a wonderful experience, and I'm just very thankful. So thank you.
Thank you, Justin. Natalie?
Well, I want to start by saying I feel so incredibly grateful to be part of PACHA, to be part of this group, to have witnessed the amazing work that's happening in West Virginia. It was just so humbling, and I agree. It's inspiring, and their passion is so contagious, where I feel like, wow, what can I do next? And reflecting on all the conversations that we've had and the incredible work, we spent a lot of time hearing about the response to the HIV outbreak and the response to injection drug use. And I was just, wondering and just curious to know about the prevention efforts to prevent injection drug use in the next generation. So I firmly believe treatment is prevention, but I also believe that we should also focus on prevention is prevention as well, and thinking about that next generation of preventing addiction and responding to families who are impacted by addiction. Thank you.
Thank you. We'll go Kay, then Ada, then Leo.
Sure. I'm going to try to say this now while I still can. At the June meeting, when I was trying to say farewell to John Weisman and Carl, you could probably understand every fifth word. So I'm trying to, I just want to say incredible thank you to the members that are terming off. The work you guys do 24/7, day in, day out is incredible. I remember when we swore in, for example, when we swore in Justin, and he said, "Hey, can you take a picture of me? I had to send it to my mom." Hey, come on. And so that's what touches my heart, the work that we do. So to work with these guys that are rolling off, terming off, is just incredible. So I did get the few words out. before, I can't say more than 2 words all collectively. So just thank you. Thank you. I call the new class, just welcome, welcome. We're here to support you, make things possible, and look forward to our continued work.
I was about to cry as well, but as I think back and I reflect, I realize what an honor and a privilege it has been to serve on PACHA. I think about all the things that each one of us do in our daily lives to, advocate for our patients. All the work that we do, and it's not easy. And many times, I was thinking the other day how weary and how tired we are, but we keep on pushing and we keep on fighting. And it's days like today and days like the last couple of days where we saw what passion and commitment that the individuals here in West Virginia have for their community. And it's all about community and it's all about the people. And it's times like this where, you end up getting re-energized and you realize why you do what you do. And I am just so thankful that I've had the opportunity to learn from many of you. I mean, because we're all doing the same thing, but in different ways and in different places. And it's just such a wonderful opportunity. And I am just so honored to have been part and continue to be part of the PACHA family. I just want to throw something out. PACHA to the people. Come to South Carolina. Okay. Thank you.
Leo?
Thank you. So I just have to say, my heart feels pretty full right now. I feel like I will be leaving West Virginia with a little piece of West Virginia. Honestly, I'm taking a little piece with me because there's just so many great experiences here. To see the level of passion and commitment to community and to serving, it's just something that will be with me for a very long time. So I want to just thank everyone who opened their organizations to us. I see Nakia back there. Thank you. And to also thank you all for all the amazing work that you do every day. You're making a difference. Even when you don't think you're being seen, you are being seen. Even when you think you aren't being heard, you're being heard. And so it's just ensuring that, you stay open to the process, because everything that you need to be able to provide the services, it's coming. I believe that. To PACHA, to our members that are leaving us, I just want to say that you all are a part of a legacy, and you have made history. The fact that we now have PACHA to the people, the fact that we're here today in West Virginia, that's something that you all started, and it's something that will continue, and we will carry the torch. And we just thank you. It's nice to be sitting on this row. Justin, your leadership with stigma and disparities. John, you and I facilitated my first panel together, as a PACHA member. And then Dr. Stewart, goes without saying, your leadership. And so I look forward to being able to call on all of you. And we will continue forward working alongside you in your honor. Thank you all so much.
DeAndre?
I just want to start off by saying how grateful I am to be here for this opportunity. For me, it's an honor, but it's also a dream come true in my career path. For the last 9 years, since I know who someone who I consider as my pops, Gabriel Maldonado, who sat on this same committee, it was something that I knew that it was a place for me to be at this table as a young person. And I want to say how grateful and thankful that I am to have watched all of you who have served on this committee be such leaders. You guys have set the bar so high for someone like myself and all of my new members. And I just want to say that I am committed to continue trying to fill those shoes and do our part to continue carrying the legacy that you all have set forth on from here. So thank you all.
And then Greg.
Hi. I just want to say, this is my last PACHA meeting, and it's pretty sad, especially with some of these new members coming in, many of whom I've known for a long time and would love the opportunity to work with on PACHA, but I understand the need to rotate off, otherwise you guys wouldn't be able to come on. So and we just grow old on PACHA. So I've been on for 4 years. It's been a lot of change over these last 4 years. We've been through now a second administration. A lot of changes there. It was some wild times. We went through COVID. We went through monkeypox. Just a lot. But I think we've made a lot of progress. I think we've done some great stuff. So I'm very proud of what I've been part of here. And I want to thank Caroline and Kay as well and the rest of the team, because you all have been just awesome. You've made it really easy for us to do what we do. And that's really great. And I know you guys, there's so much we don't even see. I'm sure that you guys have to deal with and put up with. I want to thank all the people that I've served with, people I wish I had a chance to get to know better. I think COVID had something to do with that, but it's just been really great to work with everybody. The talent is tremendous. And I hope in some way or form we'll get to work together again moving forward. I'd love to come to South Carolina. I have family there. So if you guys have a meeting there, maybe I'll show up. I assume it'll be like in Columbia or something. So, which I love Columbia, by the way. And then to the new members, as I said, I unfortunately won't get to work with you on PACHA, but hopefully some other way we'll work together. And some of you I know I'll see again because I already have plans to work with you. So anyway, new members, enjoy. Former members, great working with you. And thanks. Oh, and wait, before I end, West Virginia. Thank you, West Virginia, for being so wonderful. As I said earlier, Tony's been trying to get me here for a long time, and I definitely want to come back. And Tony, I want to continue working with you and trying to help, and do anything I can to help all you guys are doing to help other people. So thank you.
Thank you. I think for me, in terms of our visit here, the thing that really stood out is that every single one of us had a different definition of rural and what that meant. Mm-hmm. And it was really nice to see that firsthand. Mm-hmm. It was wonderful to see folks do such a tremendous amount of work with the resources that they have available, and to see the wonderful commitment that they had, the collaborations that they had, and the number of volunteers and other people in the community that were willing to come to the table and make things happen for their clients. It was mind-boggling. My mind was blown at just how successful all of the places that we visited were there. And I think it was really nice. I think this is the first visit that we've had that we didn't specifically go to HIV service organizations to learn about what they were doing about HIV. We really looked at organizations that were contributing to an individual's overall health and well-being, such that their opportunity to be put at risk for acquiring HIV was tremendously diminished. And I think that is something that we have to continue to promote in the work that we do nationally in HIV work, and certainly on PACHA. In terms of my experience with PACHA, I think it's been the pinnacle of my career. I don't know what happened to get me to be at PACHA, a combination of luck, hard work, payoffs, I don't know. But there I was. And I would just say, I was diagnosed 33 years ago at 25. I became a Ryan White client when Ryan White became available in my community. And my career and my volunteerism on PACHA started simply with somebody asking me to talk about my experience, learning my HIV diagnosis and what was I going to do after I got my 2 to 10 year life expectancy diagnosis. So it's been an honor to be here with you. And then I want to share some thoughts to the new people that are coming on board. So first, when people leave us, we talk about having big shoes to fill. And without diminishing the amazing, great work of my colleagues, the only shoes you have to fill are your own. Our membership rotates for a reason, to be relevant and responsive to the ever-changing HIV epidemic. And so I offer these words of advice to you. First, listen to Kay. Carolyn, Emily, Chloe, Kat, Stephen, and I know that there are others, Stephanie, right? Listen to them. LaForest, who will be doing your travel.
You won't eat.
Definitely make sure that all of your attachments are individual and not combined in a single document.
What's wrong?
But listen to them. All of these individuals are the epitome of the definition of a modern bureaucrat. They are collaborative, they are community focused, they are innovative, and they are ingenious. And it has been wonderful for you to set such an example for us and for the nation. The second thing I would ask is that you continue to listen to the people that we serve. Our most important work, as you saw today, is guided by input from people, our PACHA-to-the-People connections, and people joining our meetings and giving their voice. I encourage you to continue to listen to them and act quickly. The third thing was going to be a recommendation to be vocal, but all of you, I think, proved today that you could do that quite well. But just remember that when you do not speak, the people that you represent, however you choose to define who you represent, don't have a voice. And so please just be involved, be a part of a committee, take part in all of the meetings that you can, and truly try to be at every offsite meeting that you can, because it is just a wonderful experience to connect with the community. And then finally, I just want to say, when I joined PACHA, I believe I was the only individual who publicly identified as a person with HIV. And up until very recently, I think I might have been the only one on the committee that publicly identified that way. And so to hear from this side of the room and this side of the room and this side of the room and this side of the room that people with HIV were stating their status and who they were representing and what they hope to accomplish, it was wonderfully gratifying to hear. And with that, so thank you so much. We have 2 announcements to close this off, and Ada will take those.
Thank you so much, John. I just want to throw something else in. I really miss not having Marlene here as we conclude our tenure, and just want to thank her for her leadership and her guidance throughout all of this. So want to make sure that she knows that she is truly missed. And so with that, PACHA will be convening in Houston, Texas on December 6th through 7th, 2023. So, again, we look to, you all look to having wonderful visits prior to the meeting, and again, bringing PACHA to the people again. And then make sure that you visit PACHA page on HIV.gov for more details. And thank you all. Thank you so much. We are adjourned, and safe travels home.
Produced by the U.S. Department of Health and Human Services.